Hi, I'm Craig Seto with the Department of Family Medicine. Today we're going to go over the clinical exam of the low back. I think the most important thing about teaching this to medical students is understanding that the low back exam can be as complicated or as simple as you want it to be. What we're really trying to do, or the goal of our exam, is not to come up with a specific diagnosis. I think low back is much too complicated of an issue for us to do that in our one visit and our exam. So really what we're trying to determine is this patient really having low back pain due to a musculoskeletal etiology, or is it something masquerading as low back pain, such as pyelonephritis, something more serious that we need to then do further tests on. Today, to assist us with the examination, I have Denise Way, and Denise is one of our second-year residents with us, and she's going to help us with the exam. The beginning of the back exam starts right as you walk into the room. What you're doing is you're observing the patient as you go to greet them, and you're seeing if they're in obvious discomfort, and we'll do that right now. As I walk in, I'm looking at Denise. I'm saying, Denise, how are you doing? Dr. Seto?
Hello, Dr. Seto.
And I'm looking at her facial expression. I'm watching at the way that she's sitting in the chair to see if there's any painful expression that she's having, or is she slumped over? Is she bent forward as though her back is hurting her? And then I'll ask the patient to get up on the examining table, and I'm watching how she does that. So I have her walk over and get up on the table. And I'm seeing just how much difficulty she has getting up on the table to see just how much disability this pain is giving her. After seeing functionally how Denise is doing and how the patient is going from sitting to up to the table, in order to do the rest of the exam, we're going to need appropriate exposure of the back so we can see landmarks and do our palpation. So at this point, I'm going to ask that the patient disrobe appropriately enough, and if we need to cover her with something, we will. And if she feels uncomfortable, we'll bring a chaperone in to help us with the rest of the exam. The next portion of our exam is going to involve inspection. And to do this part, I'm going to ask Denise to step down. And what we're going to be doing is we're going to be inspecting posture. We're going to start from the lateral aspect and look at her posture. And sometimes I will actually sit. Okay, so looking from the lateral view, Denise, I'm going to have you come back right around here. I'm looking to see that she has a normal lordotic posture of the lumbar spine. I'm then looking up to the thoracic area to make sure that she is not a humpback or has too much kyphosis, and then right up to the cervical spine, which should have another lordotic curve. I'll then have her turn away from me, and I'm looking for the straightness of her spine all the way down, making sure that there is no scoliosis. To assist me with this, I'm going to look at the two different landmarks. I'm going to look at her scapula, and her scapula should be about symmetric at the same level on each side. You can also look at the tops of the shoulders to make sure that one shoulder isn't drooped down. And then lastly, you're going to come down to the iliac crest, and you're going to palpate it with your fingers, and you're going to step back and see whether the iliac crest is normal across the height, or whether one side is up or down. And on Denise, it almost looks as though one side, the right side, is up just a little bit, and this could be secondary to a leg length discrepancy. The next portion after we've observed and inspected the posture is just palpation. And many folks, I just like to gently palpate down on either side of the spinous processes in the paraspinous musculature. And what I'm looking for is for the patient's reaction to my palpation. This is very light palpation, and I'm trying to find, is there one area that they are most tender on, and I'm looking at the reaction to me palpating them. Many patients sometimes will have what we call pain amplification and will feel as though this light palpation causes a great deal of pain. And that's one of the things I'll also annotate on my exam. From here, I'm then going to look at the range of motion. And again, I'm not going to measure specifically in degrees. I'm getting what we call a gestalt, or just an average of what the range of motion is, because I want to know how much ability or disability does this patient have. So Denise, I'm going to have you bend forward and go as far forward as you can as far as bending at the waist. Right like that. And as you can see, Denise has got excellent flexion. I'm going to have her come back up. And then Denise, I'd like you to have you extend your back, and I'll hold on to her and let her just arch her back. Good. You can relax now. And I'm also looking for, does these bending forward or arching the back cause a great deal of pain to the patient? So not only am I seeing how much they can do, but I'm seeing what causes the most pain for them. Okay, Denise, I'm going to have you one step back here. There you go. I'm then going to have her side bend to the left and to the right. Okay. And what I was looking for is just symmetry of her range of motion. I'm going to hold on to her hips and then look at her rotation. And Denise, I'd like you to rotate to the right and look over your shoulder as far as you can. I'm going to hold on tight here. Good. How about the other side? Excellent. Okay. So basically our inspection, again, looking at her posture, we're looking at her range of motion, and then the palpation, we're looking for whether we can find areas of pain, and we're looking for her reaction to the range of motion and my palpation to see how much pain she gets with that. Okay, we've just completed the inspection, the palpation, and the range of motion, and since we don't have to really look at the spine anymore, we can then allow the patient to get dressed or put on her shirt to feel more comfortable during the rest of the exam, which we've done. The next part of our exam is going to be the neuromuscular part of the exam, and with low back pain, we're always concerned that there is some impingement of some of the lower lumbar nerve roots. So I think it's really important to remember what muscles go to what nerve roots. So we're going to start off at the upper lumbar area, L1, 2, and 3, and those nerve roots go and innervate the hip flexor muscles, the ones that would help flex the hip. And I'm going to have Denise lift up this leg and hold it up there, and I'm going to just check the strength of her hip flexors. Okay, we'll check this side now. And I'm checking for strength and symmetry of strength on each side. Okay, relax. We know then that L2, 3, and 4 nerve roots go to the quadricep muscle, and I'll check that next. I'll have her just extend her leg, hold it out there, and I'll check the other leg. You relax that one, hold it out. Okay, and relax. And I'm again checking for symmetry of strength on each side. As we come down further, we know that L4 specifically will come to the anterior tibialis muscle. That is the main dorsiflexor of the foot. So I'll have her dorsiflex, pull up her foot, and then test the strength of that and compare it to the other side. I'll have her pull up this foot and check the strength here. Good. L5 also goes down to the extensor hallucis longus, so it extends her great toe. So I'll have her pull her great toe up, and I'm just going to press down on it and compare that for symmetry to the other side. And then for S1, S1 goes to several muscles. You can pick either one, whichever is easiest for her. Your flexor hallucis longus, which helps you flex down the toe. I'll have her flex that down. Hold against me. Good. Check the other side. Again, always checking for symmetry. Pull down. The other thing that S1 goes to frequently is just your plantar flexor or your gastroc muscle. So I'll have her push against my hand like she's pushing on the gas. Same thing on this side. Very good. So we went all the way from L1 to S1, checking the muscle groups and the strength of that for symmetry one side to the other. The other parts that we want to look at is the sensation. We know that in the lower lumbar area, L4, L5, and S1 are the nerve roots that seem to be affected the most with herniated discs. So we definitely want to be very familiar with always checking L4, L5, S1. When we're looking at sensation for those three parts, I like to teach the residents or the students that L4 is always going to be on the medial side here. And the place to check for sensation is right at the medial malleolus or right above that. So I will feel there as well as the other side and ask the patient, does this feel the same as I'm rubbing on your leg? Or does one feel number than the other? L5 specifically is right over the dorsum of the feet, and I'll come both sides, and specifically right at the web space between the first and second toe. I'll rub along there and ask the patient if they feel that, and it feels the same. And then S1 has sensation to the lateral portions of the feet, and I'll rub them as well. So very quickly I can do that just by coming medially over the dorsum and over the lateral sides of the feet and check L4, L5, and S1 for sensation and symmetry of sensation. The last portion that I'm going to check right now then would be the reflexes. And the reflexes that are most important are going to be the L4 reflex to the patella. L5 doesn't have a reflex in the lower extremity here. S1 will be your Achilles tendon reflexes. So we'll check that right now for symmetry. And we'll go with the right first. We'll do that one more time. We'll try the left, which is very good. A little delayed. And if you have problems with the reflexes, again, you can always distract the patient. I'm going to have Denise kind of grasp her hands like this and pull apart. And then we'll check again. Okay, relax it. Pull real hard. Okay. And what we can do, we can always come back to it if the patient has difficulty with that. We'll go down and take a look at the S1, which is the Achilles. We'll check, and I want you just to relax, Denise. We're just hitting. And one of the hardest things here is getting the patient not to help you. They need to relax their foot and allow you to pick it up and hit, and not allow them to dorsiflex actively. We'll check the other side. Good. And the other thing that you can see, sometimes you won't actually see the foot move, but you'll actually feel the plantar flexion in your hand. So we're looking for symmetry between that. Now, if you're in a very big hurry, a quick way to look at the neuromuscular exam on a person is to have them stand up, actually go up on their toes. That checks S1. They can go back on their heels. That checks our L4. And if the toes go up, also L5. So you can have a person walk on their toes, walk on their heels in front of them, in front of you, and if they can do that appropriately, then we know that L4 and S1 is okay, and then get them back on the table and check for L5 with just the great toes this way. And that completes our neuromuscular exam for the lower lumbar spine. Okay, the last portion of the neuromuscular exam involves a special test called the straight leg raise. The straight leg raise is an exam where we're actively going to take the patient's leg in a sitting position. You can do this also in a laying position, but I prefer to do it in a sitting, and extend the leg out and try to get them to about 90 degrees. Now, if someone has a herniated disc that is applying pressure to the lower lumbar nerves, then doing this procedure will actually stretch those nerves. And a positive test would be if the patient complains of a shooting, what we call radicular sensation or electric shock, that shoots down from the back, down the leg, past the level of the knee. And usually the way, you can relax that, Denise, the way we'll record that is they'll have a straight leg raise at a certain degree of extension. So if we bring her all the way out to here, this is 90 degrees. Coming down to here would be about 45 degrees. And what you would want to say is they have a positive straight leg raise if at a certain degree of extension they experience electric shock sensations shooting down their legs past the level of the knee. And we'd like to know how far it actually goes down, but it's Specifically, if it goes beyond the level of the knee, that is a significant finding. If they only have back pain when you do a straight leg raise, that's a negative straight leg raise. So following the examination of the muscle groups for strength and sensation, checking the reflexes, and doing a straight leg raise, you will have completed your neuromuscular exam. In summary today, we've gone over the clinical exam of the low back. We're going to do this in any patient who comes in complaining of low back pain. We're going to understand that musculoskeletal low back pain usually gets better by itself regardless of what we do, and we treat that conservatively. The main premise or reason we're going to do the back examination is to make sure that we're not missing serious underlying pathology causing back pain, and certainly we would like to know whether we have a significant herniated disc which is causing pressure on nerve roots. So doing a complete back exam will give you usually a very good idea of whether we have a herniated disc, whether we have serious underlying pathology, or just the run-of-the-mill musculoskeletal back pain that usually gets better with conservative care.